Welcome back to the Doc Talk podcast. I'm Dr. Shazma Mathani.
And I'm Dr. Sheila Wijaya-Singha. And today we have made it. We are at the final recap of season 1 of The Pitt, covering episodes 14 and 15. It has been such a ride to rewatch and do this with you, Shaz.
Absolutely. And I mean, I'm getting so excited for season 2 coming up in just a couple of weeks here. So these hours for episodes 14 and 15 take place between 8 p.m. and 10 p.m. It's that final stretch of the same nightmare shift we've been seeing all season long. I honestly don't know where any of them, like how any of them are still standing upright at this point in the show.
But before we get into our usual case breakdown, we have a very special guest with us today.
We are thrilled to welcome one of the medical advisors from the show, Dr. Jacob Lentz, who helped create so many of these moments we've been obsessing over. Jake, welcome to the Doc Talk podcast.
Thanks for having me.
You are on set right now.
Yes.
And so thank you for taking the time out of your schedule to do this.
It's okay.
We've been waiting to chat with you because we're 2 docs in Canada. I'm a family doc. Shaz is an emerge doc. And we have loved The Pitt so much. And
well, I love Canadian
listeners.
medicine, so I like Canadian doctors, so my pleasure.
Love it. Love it.
So we've been trying to ask you, how did you get involved in the show? Because it's not your typical hospital-based drama.
Yeah, so a friend of mine last April 2024 had just sent me a Facebook post, and it said if you're an ER doctor in LA, in Los Angeles, in California, and you have any experience in film, you might want to send your CV in for this new show that's going to be called The Pitt. And so I sent in my CV, and that's the story.
I love that. One thing that I've always wondered and that we've always wondered is how much of what we're seeing on The Pitt is based on real cases or real clinicians?
So I don't know because I can't fully answer that because I'm like an on-set medical consultant. So I'm not involved in the writing. I'm not involved in creating the stories. I think, but I do think a lot of the stories, a lot of the plot lines are based on real cases that either people have firsthand knowledge of, just not me, but some of the writers, or like have been discussed on podcasts like previously, like there's a lot, I think they sometimes you'll hear these cases on podcasts of like rural ER medicine cases that are just bonkers. And so
well, it's like that. Is it like
yeah.
that? I mean, I'm sure you listen to EMRAP. I do as well, but there's that rural medicine segment that they have. And like those cases are bonkers. I'm guessing that's kind of what you're referring to. Hey,
bonkers. So I think they've gotten some stuff from there. So yeah, there's people sharing stories. And so, yeah, I can't say for sure because that's not what I do, but I think there's a combination.
Tell us more about what your role is on the show.
So I'm on set right now. We shooting each episode is 9 days, so I'm on set for that entire time. So it's like basically 12-hour days, and then I have to go through each script when I'm responsible for an episode and give notes about what the props, the makeup, the wardrobe, the monitors, what everything looks like for that episode for each scene. So that's usually about 20 to 28 pages of notes. And then I have to, for any medical thing, I have to kind of choreograph what it's going to look like and who's going to be doing what where. And then I'm there to answer questions for everybody.
That's great. And we when we met with Fiona, she mentioned that she did a mini med school kind of couple weeks just to learn how to do the procedures and maneuver around. Were you part of that as well? Or
So
is that
I was there for that. Yeah. So that's, we did like a week, I think, of boot camp for the actors and just kind of try to explain to them, teach them, how doctors think and how, like terminology and like how we think about disease processes and how we work up like a differential and things like that. So, kind of, I think probably stuff that kind of for doctors is very basic or just, kind of, but we probably take for granted. So,
Did you
so
say
I think to other
episode...
people it's totally foreign. Like I think as doctors we lose sight of how completely bizarre so much of what we say must sound, and just makes no sense to other people. But we're just all used to hanging out with doctors, I think, and just using all these fancy words, I think.
I think that's even just thinking about how, like, the feedback that I give to medical learners early on in their careers about the way that they talk to patients and like not using medical jargon. Yes. I think you're absolutely right, because we live in our own worlds of like how things sound to us and how things make sense to us, and don't really think about what the outside world gets or doesn't get. So I totally hear that.
Yeah. So it's kind of like, I think the function of the boot camp was in a lot of ways to kind of acclimate them to like this whole other, witch doctor world that we inhabit, where we just say a bunch of magical words and hope everything works out.
Did you say that each episode is 9 days of recording? Did I hear that correctly?
Yeah, it's 9 days of prep, 9 days of shooting. So yeah, it's a lot of work. It's a lot of work. It really is. Like that's the number one thing I would tell people is, I think some of my friends now think I have this like sweet job where I just hang out on set and order a latte and yell at an assistant. And while I do yell at all the assistants all the time, it's just a lot of work. It's a lot of work.
How do you balance this with practice? Like you're practicing in the Emerge as well?
Yeah,
or do
I'm
you take
exhausted.
A bit of some time?
Yeah, I'm exhausted. Yeah. I'm just physically exhausted.
So, I mean, one of the things that we talked about on the show, on our podcast, is just how medically accurate everything is. And it sounds like that's your role, right? And so when we had the STEMI case, for example, you look at the ECG, I'm like, yep, that's exactly what I would see in the Emerge if that happened. Or like looking at a chest x-ray of, the measles case, for example, recently in this episode of 14 and 15, like looking at the chest x-ray, looking at what the rash looks like. So these are all things that you are contributing to ensure the medical accuracy of what we're seeing on screen. Is that correct?
Yeah, so that's correct. So, so a lot of stuff gets run past me. So you're kind of, the onset doctor, there's two other doctors who work on the writing staff, and they also are involved in kind of screening stuff and approving things. But yeah, you're kind of the easy button for everybody. So you're just constantly answering questions like, what does that look like? And is that too much blood, or how would that work? The weird thing that I bump into is, that kind of like those things where you're like, I don't know, that's kind of what I do. And you're like, I don't know if that's like if that's right. Like, I'm like, well, you could just like just have them put on a gown, but they can keep their pants on and also their shirts. And like, they're like, what's the purpose of a gown if they're fully clothed? I'm like, I don't know. That's what patients would, half the patients are fully clothed under the gown. And you're like, I guess that's more realistic, but it's kind of not right. Then there's also a lot of questions about like, should they have gloves on? And I'm like, I think yes, maybe. But like, you're like, it's like, there's no blood. Like, so you get into those things where you're like, that's what I do. But like, if I'm grabbing if you're wheeling a gurney back from a CT scan, do you put on gloves? I don't know. I feel like, I don't know. Maybe I don't. Maybe why would I have gloves on? Like, I'm just pushing a gurney. Do I need gloves for that? I don't know. So you end up in these situations where you're like, that's kind of what I do, but I'm not sure. Like, I always stress about like what other doctors are going to think, that they're going to be like, this is just so careless. I'm like, well, yeah, that's what you get when you hire me. So I don't know. So it's, that's where I get confused. There's sometimes, how also in medicine, how there's, I think we're all very comfortable with the idea that there's often not a firm, definite answer, that there's like, well, I was like, today I literally said like, as we say in medicine, I think that's reasonable. But it's like, it's hard to explain. Like, so it's kind of like, I think sometimes people just expect that there's going to be like a definite right answer. And like, sometimes I'm like, that's what I do. I don't. So it gets, so there's a lot of things that have obvious answers. Like should that chest x-ray look like? And then there's also like kind of just protocol. And, obviously there's times when you definitely have to do things a certain way. And then sometimes you're like, I don't know. I think there's some fungibility that I always worry I'm going to like misrepresent our field.
Well, as an Emerge doc, I will say that my field feels very well represented.
No,
so
thanks.
I'll give you that feedback. It's been like all Sheila and I have been talking about during this series that we've been doing is just like always about how medically accurate the show is. So hand clap for that one, because you and your team have been doing a great job on that.
Well, either we have great. Really, honestly, the other thing I will say about this show, and like it just reinforces, like if you have a bunch of people all just trying to row the boat in the same direction, like you can get a lot done. Like we have incredible. The makeup people are like geniuses. The prop people are fantastic. The wardrobe people are fantastic. Like I'm not just saying this. Like even like the set decorator and the set design, like they just think about things in a completely different way. Like they're just genius. It's so it's really nice to just deal with those people, because like they'll just deliver on whatever needs to get done. But yeah, it's like if you have a good group of people who all want to do the same thing, you can get a lot done.
We really, one of the other pieces apart from the medical accuracy that the show has is like the heart of medicine is very well portrayed in this show, and like the hard moments that a lot of the public don't get to see, and how we talk to our patients, how we communicate, how much it impacts us as clinicians. Like that is so well done. Did you have any moments that really stood out to you in season 1 that you like, cases that you felt really hit home for you, or was it many? Or
so so you're right. I mean, like, so I'm involved in the writing of the show, but does a good job capturing like that. This is often it's like a very privileged. I always think of our job as like tremendously privileged and also tremendously difficult. But I think to answer your question, I think there was one thing where there was the nurses were cleaning a body of a patient who had been killed in a car accident. And it was really, for whatever reason, it reminded me of being a medical student the first time I helped clean up a patient who had coded and passed, and we knew their family were coming. And so I ended up helping them prepare the body. And it really was like, I don't know, I think I'd kind of forgotten about all that, or at least stopped thinking about it. And then all of a sudden there's like this very well done makeup job that really sort of reminded me of that moment. It was borderline emotional for me.
Yeah, and I mean that really comes across in those scenes. That's another thing that Sheila and I have talked about a lot, is just that heart of medicine that comes through the writing, and even just what we visually see as well. One question and Sheila and I often talk a little bit, like very rarely, about the inaccuracies, because there aren't a lot of them. I have to say, like, this show, in my opinion, is one of the most medically accurate shows in existence. And it's been so great to see my life as an Emerge doc portrayed on live TV as well. So the mask piece, though, like, so in my Emerge that we work in an inner city Emerge, we're masking pretty much for every patient. I suspect that was an intentional decision to not have the actors wear masks. Can you tell us a little bit more about that?
Yeah. So I think, conversely, I work at a urban ER, and I try to avoid wearing a mask as much as I can, because I got just so tired of wearing masks during COVID. Unless I'm around someone who's like immunocompromised or a neonate or something, then yeah, okay. But I know it had come up, and it was sort of like, well, it's not good television if everyone's covered in a mask.
Yeah.
So it's hard to have affection for the characters if you can't see their faces. So
for sure.
So our last question, just so we know that you're on set right now. We're really excited for season 2. We have been, all our listeners are rewatching it with us, and we've been recapping. Probably can't share very much, but we just saw the trailers come out today.
Oh yeah.
Anything exciting that you're looking forward to for season 2?
Well, I don't want to get fired, so
please don't get fired on our account.
I think I'll just say they've done a very good job maintaining the pace and the tenor and the humanity of the show. I think people will be happy. I really do. But I don't want to give anything away. There's spoiler alert. There's a bunch of medicine.
Love it. A bunch of accurate medicine.
Hopefully, yeah.
Wonderful.
That's what we're hoping for. Yeah. But yeah, that's I think it's gonna be good.
This was such a treat, Jake. Thank you so much for hanging out with us today and giving us a peek behind the curtain.
Pleasure.
I mean, for me, it's very clear, like with people like you on the show, that there is clear intention to keep this show as medically accurate as possible, and like that they have hired medical advisors like you and your team really speaks to that. So thanks for chatting with us today.
What's interesting is I think it really speaks to like if you right, like most of the audience doesn't know if it's accurate or not, right? Like most of the audience didn't go to medical school, but they can tell, right? And like that's what's so interesting. I'm like if you treat the audience as intelligent, and you respect the intelligence of the audience, I think they'll pick up on it. And I think that's what's so interesting about this experience to me is like people just know. And so I'm just glad to be able to like play a small role in helping to like bring some light or shine a spotlight on like the job that we do that I think is just, it's a hard job and we don't get a lot of appreciation.
Thank you so much.
No, thank you guys.
Thank you for taking the time out of your schedule. Thank you for being a part of this. It has made such an impact for all of us watching, and has helped us have conversations with our patients that we haven't been able to have as easily as well. So we really appreciate the work that you do, Jake, and for joining us today. I'm
a small cog in a larger machine, but thank you.
What an insightful look behind the scenes from Dr. Jake Lentz. Like, let's finish up this season with some of our favorite cases now, Shaz, from the last 2 episodes of season 1.
And we're diving into some really heavy medicine and really heavy emotional arcs. We're sticking to the big ones, though. Mel's breakdown, the measles case, Santos's pivotal moment, the pelvic crush, and finally, that rooftop scene that ties the entire season together.
Yeah, there's a lot here in the last 2 episodes. They certainly didn't spare us any feelings for this last 2 parts.
Definitely not.
So let's start with Mel's breakdown. One of our favorite characters, Shaz, Dr. Mel King, the scene where she's sitting with the grieving family member who was affected because she had witnessed her own husband die in front of her at Pitt Fest. And she asks Mel, how do you deal with this death and carnage? And all Mel can say is, I don't know.
This one, this is one of the most realistic portrayals of clinical burnout that I have ever seen, because really you can't deal with things in real time. In the moment, you kind of compartmentalize things. I certainly do that. My colleagues do that, I know, because you really have no choice. You have all of these tragic things going on around you. And if you let those emotions get in for even a second, it feels like you will completely unravel and not be able to then care for all of the other people around you. And so you're really just in survival mode.
Yeah, I imagine you feel this quite a bit in your work, Shaz, as an emerge doc. And, we see it with Mel here, where it hits her suddenly, like the impact of everything that she's seen during this day, this difficult shift. The adrenaline kicks in, but then it drops. The cases slow down for a half a second, and the weight of everything just crashes on top of you.
Yeah, and that is exactly what happens in real life. The body kind of waits until you're safe to fall apart. And then for emerge doctors in particular, that safe moment often doesn't come until hours later or the next morning or even months afterwards.
Yeah. Let's go on to a measles case here, because this was a big one that spanned several episodes, 2 episodes really. And it was very important, especially given currently what we're seeing in Canada and the US and around the world, where we're seeing measles emerge again as a public health issue and a public health crisis, really. And it was really one of these most gut-wrenching cases that we've seen, where a sibling pair is brought in, where one of them is very sick with a fever and a rash.
Yeah. And from a clinical standpoint, there was a lot of accuracy here. So that chest x-ray was very accurate. That bilateral kind of quote unquote patchy consolidation is very classic for measles. The clinical picture was very textbook. So they had the Koplik spots, which are the spots in the mouth. There's a high fever, a cough, the red eyes or conjunctivitis, and that classic measles rash.
And I think Shaz, it's like textbook in that we learn this in a textbook.
Mm-hmm.
I remember all of these terms from medical school, but I never thought that we would see this. And what was so striking on this scene was that it was like none of the clinicians who were part of the team evaluating this patient recognized what was happening, despite like us learning about this, because measles is not something that we haven't really experienced.
Well, that's just it, right? I mean, up until recently, it really just has been our textbook learning of this because we haven't seen measles to this volume and this number of cases in decades. It's never really, up until recently, been diagnosed in my career. And that's just because that's how good vaccines are, or I guess were, up until like this big drop in MMR vaccine uptake.
Yeah. And so let's do a little teaching corner here around what do people need to know about measles, Shaz. So tell us a little bit about measles.
So yeah, measles is actually one of the most contagious viruses on the planet. So one infected person can infect up to 18 other people. And there are a couple of reasons that it is so infectious. One is that it's transmitted by airborne transmission, which means that the air that an infected person breathes out, if somebody else breathes that in, there's actually a high chance of that other person getting measles. But then the kicker is that it actually lasts in the air for up to 2 or 3 hours after the infected person leaves the room. So it sticks around in the air. So someone can like leave a room, another person can come in, and they can actually get infected with measles. It can have a significant number of complications, including things like pneumonia, encephalitis, which is brain swelling, and ADEM, which is kind of this generalized swelling and inflammation of the entire nervous system that has up to a 20% mortality.
And this is where vaccination really comes in, because vaccination prevents almost all of this. And unfortunately, in Canada, we were considered to be measles-free in 1998. And since then, that's why we haven't really seen it in practice, right, Chaz? But we've lost that status recently. And a lot of that is due to under-vaccination. Then there's also this moment, Chaz, that really stood out where I think all of us who work in healthcare were screaming at this scene between the conversation that Robbie was having and trying to get the buy-in from the mom and the parent duo to intervene and to do the lumbar puncture. And he loses it on the parents.
Yeah, I mean, I could absolutely empathize with that. Was it appropriate? Not really, but was it human? Absolutely. Like all of us as clinicians have felt that frustration, especially in the context of vaccine preventable illnesses like measles, because we just want to protect kids. And these families are running into misinformation and mistrust, and it's just such a frustrating moment. And so I can absolutely empathize with Robbie there.
Yeah, so the key take home from this teaching point is if you have not been vaccinated or under-vaccinated, please consider doing so, because measles has very significant complications and potential long-term health complications for you and your family members. Okay, so we have this very interesting that I've never seen personally, but it was so fascinating. The case where Santos had a really great moment where we jump into the kid who presents to the emergency room, Max, totally blue.
And the thing that I loved most about this, so he has something called methemoglobinemia, which is like super, super rare. I've never actually seen it in my career because of how rare it is. But what I loved here is Santos's instinct. So something felt off to her from the start, and she didn't ignore this spidey sense. And this, I think, is like just such a underrated emerge skill, and she nailed it.
And this is really interesting. As the case progressed, they were doing a bit of detective work, which is a lot of what we do in medicine. And she was trying to tease apart, like, could this be due to some form of like an ingestion of something that he ate? Could it be a drug that he took? Is there a risk of an attempt to end his life? And she took a lot of time to sit with him. And this is a rare thing that we see Santos do, because she sat at his level. She shared her own personal story and had a breakthrough.
And for me, this is her best moment all season. I was, after Santos is rough around the edges, right? We've talked about this in previous episodes, but this was like her shining moment that really brings the humanity. So it's not the medicine, it's the humanity. And it really brings this, this kind of rumbling backstory that we see of her, where we see that she clearly has significant life experience that she's bringing to medicine in such a positive way. And this is kind of the culmination and the win of all of that.
For sure. It was a really nice character development moment, right? To learn about her and also see how it helped her clinically. And then she advocates for psychiatric support for this individual, because she knew that it wasn't just a toxicology case. There was more to this story, and it was really, really lovely.
Mm-hmm.
Okay, Shaz, so the next big case that we saw was a pelvic crush injury from the loading dock within the hospital.
Yeah, and so this is one where I think, like, again, so medically accurate, which we've talked about before, because as you see here, pelvises can hold a lot of blood, like liters of blood. And once you're bleeding into that space, you can crash really fast, and it's really hard to control that bleeding. So I want to get into a teaching corner for our medical learner listeners, Pelvic Trauma 101. So pelvic fractures can hide massive amounts of internal bleeding, liters, as I said. And the first step to try to stop that is pelvic binding. So you literally take a binder and try to kind of close with pressure, physically compressing it to try to slow that hemorrhage down. One of the things we also saw in the show is that we practice something called permissive hypotension. So in certain cases of trauma, we try to actually keep the blood pressure a little bit on the lower side because we're trying to avoid blowing the clots that have formed with overly aggressive fluid resuscitation or blood resuscitation, because then that can actually end up leading to more bleeding, which is what we saw in this case. That overshooting of fluids really is that underlying principle that was kind of violated in the show. And another kind of take-home point is just to make sure that permissive hypotension is at least thought about in this context, because it can actually worsen the situation if you overshoot that blood pressure.
Yeah, that was a moment, when that happened, because it was like they were doing everything that they could, and then it sort of backtracked a little bit. And this is all happening in the show at like the what hour now? How many hours after Pitt Fest? That cognitive load, I just sort of, it made me really reflect on how in Emerge, you don't know what's going to happen at hour 1 versus hour 7 versus hour 11. Sometimes if you're doing a 12-hour shift, and you're tired at this point too.
Absolutely. I mean, like, I feel terrible at the end of like a 10-hour shift. I can't even imagine the cognitive load that these medical providers are feeling right now, because in a much shorter shift, I'm feeling it a lot. So that's a really good point, Sheila.
So the final scene that we see here, we'll close to the final scene, is the rooftop scene. And it was like a full circle moment, because this is how the season opener started, with Robbie on the roof.
I love this because, I mean, like you said, episode 1, we had Abbott up there at the end of his shift. He was clearly not coping well. And now the roles are reversed. We have Robbie up there. He's really broken open by the weight of this shift. And you have Abbott coming to console him.
And there was even a moment where Abbott, this part I really loved, when Abbott disclosed that he has a therapist that he sees. And that was like the toughest guy on the show, is disclosing that it's okay to get help. And this is a conversation that, Shaz, I'm sure you have all the time in the Emerge. I have it. And also in our personal lives, like to actually disclose and be like, it's okay to get help. Life is hard. Life is messy. And when Abbott said that, I felt like it also like helped the viewers to know, oh, okay, a character like this needs help. I also could get help.
And that final, like, there's a line that comes through that, again, like, comes full circle from the beginning, because Abbott at the beginning says, I don't know why I keep coming back. But then he also says, I finally understand why I keep coming back. It's in our DNA. We can't help it. And like that full circle moment of the rooftop and like almost responding to the question that was asked in that first episode was just like pure cinema. It was so, so good.
Is it in your DNA, Shaz?
I mean, it must be, because I keep going back.
I keep running from it, so it certainly isn't part of my DNA. Family medicine's my DNA. And so that's what I guess emergency medicine feels like. It's like heartbreaking and miraculous, like sometimes within the same moment, it feels like. So let's end off with our episode awards, our last of season 1. Shaz, who was your MVP of these shifts?
So this one actually was pretty easy for me, and it was Santos, because I was waiting for her to have her moment, and it did not disappoint. So this is, I mean, it shows such high EQ from her, and it's her like peak moment of the entire season. She recognized risk, she connected with Max and advocated for the psych support at the very end of a long shift, right? And so she could have just dismissed this, but she saw something, stuck to her guns, and then that's what really makes an exceptional physician.
And what about the most accurate case?
For me, it was the measles and the sepsis management. And so that clinical presentation, like we talked about, the chest x-ray, the rash pattern, the deterioration of this child, it was spot on. And then, of course, the realism of that frustration that we feel as clinicians interacting with these situations. All right, Sheila, and for you, what was your best line of the episode for this one?
So my favorite line, which I think is one of my favorite from the whole season, is never apologize for feeling something for your patients. So that was Dr. Robbie to Dr. Mel King, where she sort of breaks down a little bit and apologizes for what she felt. And I'm like, that is such a real moment too, and so lovely, because we are human. We will feel things when our patients are experiencing negative or difficult times because we are feeling it too. And so
that one,
I love that one.
That was such a good one because I think it really brings home just like shows that healthcare workers actually do feel things for our patients. And even though we don't necessarily show it on the outside when we're in that patient-facing interaction, we carry it home and we feel it. So yeah, I agree. That was an awesome line.
So before we close this season's recap, let's quickly look ahead to season 2, Shaz.
Yeah, I'm so excited for season 2. There have been so many reels and trailers floating around for season 2. There's a couple different versions. We know that it drops right away here in a couple weeks on January 8th, 2026. And it sounds like the team has heard feedback from fans. So they've incorporated characters like nurse practitioners, respiratory therapists, and more. So what about you, Sheila? Are you excited? What are you wondering about season 2?
Yeah, so I mean, season 1 ended with a lot of questions for me around what's going to happen to Nurse Dana? Is she coming back? Because she took down those photos of her family off the desk and she was walking out with those. And I'm like, is she going to come back? I really hope she does. She won a Golden Globe, right? So I'm hoping that she comes back.
Yeah, me too.
Langdon, what's going to happen with Langdon? There was a big climax with Langdon and Robbie together outside in the ambulance bay fighting, and is he going to make it back? Is he going to be reported? What's going to happen there?
And what's the relationship with him and Robbie going to be like, right? Because they, at the first part of the season, before all this stuff came out with him inappropriately using medications, you could see that they really, he was such a strong and important part of Robbie, his protege almost, right? And so it's going to be interesting to see what that relationship is like after the big blow up at the end of this season.
So that wraps our recap of season 1 of The Pitt. Thank you for watching along with us or rewatching with us, and for sending us your questions and letting us take you behind the curtains of emergency medicine.
And a huge, huge thank you to our special guest today, Dr. Jacob Lentz, who is a medical advisor on the show. It was so great to chat with him and get that behind the scenes look.
As always, this podcast is for general information purposes only and does not replace professional medical advice. While we are doctors, we are not your doctors. If you have any health concerns, please talk to your own clinicians.